Good evening. Guess what time it is? It's 4 o'clock in the mountains, which means 6 o'clock on the East Coast and 3 on the West. There is one place to be right now, so settle in and welcome. It's so nice to have you with Fertility with Fink and Friends. I am Fink, and you are Friends, and we are live from the beautiful city of Colorado Springs, Colorado, where I am the clinical director of IVF services at CNY Fertility, Colorado. And as always, every Tuesday afternoon, this is the place where we get together and talk about things that are important to all of us. So we will have a chance to try to get to all your questions here. So please throw them my way. It is great to see all my old friends being here. First, very special hello to Angela in the beautiful state of Minnesota. You are number one and a fine cardiac nurse practitioner you are. Congratulations, because you have just passed your 12-week pregnancy mark, if I am not mistaken. And I hope it's okay to tell that out to the world. I think you're spreading the news now. Thank you for being number one here on my Instagram side. Over here on this Instagram side, we've got CNY Instagram over here. And the first one joining looks like Rochelle Lee. Thank you so much for being here. Who else we've got? We've got Leah. We've got Miss Michelle. We've got Nikon Girl. Let's see. Molly Maroney is here. Jay Daniels, 31. Thanks for being here. Ari Rose. Hello to Jess and Jen Wing 05. Catherine Roberts looks like here. Hey to Crystal. Nice to see you here as well. Faith Waring, good to see you, Faith. We haven't seen you for a while. It seems like maybe you were here last week too. And let's see, who else is over here? Well, we have a very special guest here, actually number two on the CNY Instagram side, which is a special friend from Miami, and that is Zenny. Thank you, Zenaida, for being here as always. And I have a special shout out to Zenaida because she was kind enough to send me one of the coolest gifts I have received. So in honor of Father's Day, and I think we can talk about that because that's coming up this weekend. And I hope I actually, very much in my heart, hope you will all have a chance to be the recipient of a Mother's Day and a Father's Day if you haven't yet in your own lives. So that is certainly coming down the pike for you. But I got this super cool hat from Zenaida, and it says, best dad ever. It's got the little whole medical thing here. And look, it's got sort of, actually, they do resemble my kids, Max, JB, and Ruby. And this is this is really a wonderful, beautiful gift. And it's really cool color too. And for those bad hair days, I think I am now absolutely all set. Zenny, thank you so very, very much for that. T. Andres, welcome. Hi, Linda Wintrang, Indy Scorza, Amanda Mallon, my dear friend, as well as Mrs. Vence, coming from Kentucky is the name of the state. Took me a minute there. Special hi to Brandis, who is here, our wonderful nurse practitioner in Colorado. Hi, Meredith Tinoco, calling from Miami, and Kayla Thompson, our nurse supervisor right here at CNY in Colorado. Over here in the middle, we've got Facebook and LinkedIn and YouTube. And who do we have with us over here? Special hi to Millie, nice to see you today. Liz Fisher, happy Tuesday from Wisconsin. Thank you so much for being here. Phelan Bowers, looks like our Arika, Renee, nice to see you, and Britt here already. Let's jump right into some questions, shall we? But you know what? Before we do that, do want to say a special hello also to my beautiful mom and dad, who I haven't seen on here, but sometimes they're watching on YouTube and not on Instagram, so I can't see that they have signed in here. But it is always a pleasure to know that you are never far from me, and I am never far from you. Father's Day means a lot, doesn't it? I I'm one of those people who I don't, all these holidays that are often kind of made up by Hallmark just so that you can go buy a card. Do you know what it costs to buy a Hallmark card these days? It's really, it's outrageous. It's $5, $6, $7 sometimes to get a card that somebody's going to open and look at and appreciate. And then, probably, well, I save them all, but I'm a pack rat. And honestly, it's here's what I am suggesting. Make a card. You know what? If you're going to do a card and Father's Day, to be a recipient on Father's Day is a really wonderful thing. But if you're doing something for your dad, you know what? Make a card instead of buying a card from the store. Because when I get a homemade card, to me, I think that is so incredibly special. It has so much more meaning. It's nice to get something that somebody else thought was cute, but I hate to see somebody spending $7 for a card that's going to come out of an envelope. Make it and send it to the ones that you love. And you know what? If it's not even for Father's Day, maybe it's for a birthday, maybe it's just a special day when you want to say hi, you're thinking about somebody. Make it yourself and send it to them, because I think that speaks so much from the heart. And kindness is such an important thing in our world. So much so that my dear friend Jody put it on the sign behind me: every day with kindness. Kindness, there's not enough kindness in the world. So celebrate it. Try to pass it along to the next guy, because it really does ultimately come to pay back. All right, so let's see here. Phelan is asking, what do you think about PMP for FET? PMP. Not sure I know what PMP means. It sounds familiar, but I'm blanking on it at the moment, Phelan. So throw that back in here and we'll try to get back to that question. Neri says, I had a modified natural transfer of a day 3 embryo a week ago. I'm currently on 1 milligram of estrogen and multiple doses a day of progesterone. 2 days later, after transfer, my estrogen was 160 and the progesterone was 34. Today, the estrogen dropped to 26 and the progesterone to 16.5. Quite confused and worried about what it means. Okay. So does that mean I'm not pregnant? No, that does not mean that you are not pregnant. So you did a modified natural. So you are on letrozole for ovulation induction. Letrozole is going to lower your estrogen level. The estrogen level after a transfer really does not matter at all. It does not correlate with outcomes. Frankly, I wish that we didn't check it. The most important thing about estrogen is, was it enough estrogen in order to give you a thick enough lining? So forget about the estrogen level. The estrogen level is not relevant to you, and it is going to be artificially low because of the estrogen. And I think you said you're on and you're taking some estrogen as well. So the only reason I would have given you estrogen is if your lining wasn't thick enough. So not sure what else, kind of was going on there. The progesterone. Now, in a modified natural, we really only need the progesterone to be, or in any natural cycle frozen embryo transfer, we're looking for that progesterone to be above a 10. If it's a 20, if it's a 23, if it's a 28, or if it's a 12, doesn't really make a difference, because as long as it's above a 10, it is sufficient to be doing its job. So why does the number fluctuate? The number fluctuates because of the way you metabolize progesterone. And there are lots of different features in every individual's body that changes how you metabolize those things. So as long as it's above a 10, and in nature, you know what the number is that you need, like in a natural pregnancy? It's about a 2.5. So we build in 5 times the amount of progesterone that you need for that natural kind of cycle FET, more so than you need even if it was, in a totally natural cycle, like let's say home intercourse or in a natural pregnancy. So in a medicated cycle, we look for that number to be above 20. And so if it's, sorry, a little bug there. If it's If it's and in a medicated cycle, if the number is 22, if the number is 30, if the number is 40, it's not that more is necessarily better. Even if the number is super high, well, if it's super high, we try to bring it down. But there's no evidence that there's a number in the progesterone scale that's too much. Remember, in a natural cycle, in a home intercourse cycle, or in a cycle that's occurring in nature, the progesterone number needs to be a 2.5. Medicated cycle, we look for it to be above a 20, and in a natural cycle, above a 10. Other than that, as long as it's above that number, the fluctuations and the changes do not matter. And please don't pay attention to an estrogen number. It is not relevant as long as your lining is thick enough. So good luck, Neri. We'll keep our fingers crossed. Okay, so Phelan came back and said PRP, not PMP. Okay, that makes more sense. What do I think about PRP for a frozen embryo transfer? So one of the things that we offer is a PRP wash prior to doing an embryo transfer. What is a PRP wash? PRP is platelet-rich plasma. Platelet-rich plasma. What the heck is that? Well, if you saw a couple of weeks ago, I did a video on my Instagram about intra-ovarian PRP, and so please take a look. I think it was actually a very good video, if I may say so myself, about how about what PRP is, how it works when we place it in the ovary. PRP is when we take a tube of your blood. So draw a tube of blood from your arm, and we are able to separate out your body's healing components, your tissue factors, your growth factors, all the things that are good that would normally be lost in a regular old tube of blood when you spun it down. And we're able to separate those out and do good things with them. What can we do with PRP? We can grow back hair. Maybe I could use a little PRP back here, actually. I'm going to stick on this side. Maybe it's my better side. You don't see the embarrassing things happening over there. We use it particularly in facial aesthetics. It's used a lot in combination with filler. There is something that's called a vampire facelift, which is using PRP fully by way of injection. We can put PRP into injured joints and in orthopedics. We use it for something that's called the O shot in gynecology, which helps both with continence and with orgasmic function. And in the IVF world, we can put some PRP into the ovaries, and that some people consider ovarian rejuvenation. And when we use it inside the uterine cavity, it is probably the most I always say it's the most healing salve your body can make, and that we can put back into your body. I think that intrauterine PRP is best served for people who are having one of a couple of different problems: recurrent pregnancy loss or recurrent implantation failure, or in a situation where we just are having a hard time getting your lining thick enough or getting that uterine lining to be healthy in some way. That's the best indication for using intrauterine PRP for an FET there, Phelan. And our Arika says, what exactly am I looking for? I need just IVF, right? When I have no issues getting pregnant, I just don't have fallopian tubes. Okay, so I would put that in a different way. You do have issues getting pregnant because you don't have fallopian tubes. So it doesn't really change the way we treat you, Arika, because we dose the medications for IVF based on your age and on the blood test that we call the AMH, the ovarian reserve. Those two things predict for us how your body may respond to the medications. So yes, you are correct. What you need, since you had your tubes removed or since you had a tubal ligation, is in vitro fertilization, because in the process of in vitro fertilization, we are revving up the ovaries in order to get them to produce as many eggs as we can get, which we then retrieve from the ovaries under a little sedation. Eggs go to the laboratory. We have partner sperm. One sperm goes in each egg, and that makes your embryos. And then we can take those embryos, and place an embryo back inside of you. Hopefully that embryo sticks, and then you're pregnant, right? So that's the process of IVF. Normally, pregnancy occurs when the sperm and egg meet one another in the fallopian tube. So since you don't have fallopian tubes, that means that, yep, there's going to be a problem. Sperm and egg, there's no highway for them to get together on. So that is what you need. You need IVF. And as far as, how we would treat you, it's not that, oh gosh, someone who was at home and has been trying to get pregnant for the last, 5 years and has been unsuccessful for reasons that we don't understand, that they are going to get some different kind of treatment necessarily with IVF. Because again, the dosing of the medication is going to be based on your age and based on the AMH. So Erika, hopefully that is helpful. Hello to Mel Bell. What instances will you allow transferring to euploid embryos? So euploid embryo is an embryo that's known to be chromosomally normal. It is one that means that you have done PGT-A, pre-implantation genetic testing for aneuploidy. When folks do PGT testing, or rather this, let's put it this way. This is the way I look at PGT. If you do IVF and you place an embryo back inside and it doesn't stick, in most cases, the reason for that is because it's a chromosomally not normal egg creating a chromosomally not normal embryo. Sometimes it can be a sperm problem. More often than not, it's an egg issue. But nevertheless, one way or the other, we've created a chromosomally abnormal embryo, and a chromosomally abnormal embryo doesn't stick. So if you have a large group of embryos, you can do PGT testing in order to separate out those that we believe to be chromosomally normal. And if we know that you have a chromosomally normal embryo, then we know that embryo has the highest probability of being able to get you pregnant. And that is a 65% chance with the very first chromosomally normal or euploid embryo. Now, in your case, Mel Bell, you've got multiple euploid embryos and you'd like to put in more than one. There are some guidelines that we follow that come from the American Society for Reproductive Medicine, or the ASRM. And the ASRM tells us that really what we're after here, irrespective of what you believe that you want, we want to give you one healthy baby at a time. Now, there is always going to be a risk of multiple gestation when doing the IVF process. But what we really want is one healthy baby at a time. Why is that? Well, when there's more than one embryo in there, and that creates a multiple gestation, twins or higher, it dramatically and substantially increases the risk for pregnancy-related problems, including pregnancy loss. So that's obviously not something that we want. Everyone knows someone who has twins, and you probably know some twins yourself, and gosh, it's very cute. And when you have twin babies, then it's very endearing, and you can dress them up the same, and and you put A on one and B on the other so you don't get them confused, and it's a lot of fun. It is a very endearing thing to have and to see cute little multiples. However, it significantly increases the risk for preterm delivery, for lifelong complications as a result of preterm delivery, for prolonged NICU stays. It increases the risk for cerebral palsy and birth defects, as well as miscarriage and pregnancy loss. So, it's not something that we are after for you. There are some people who say, well, I just, I don't care about all that. I want to have multiples. Most IVF practices will not even entertain that conversation with you. It is unethical to do so. At CNY, we do believe that you have the autonomy to be able to make your own choice in that. We may not support it. We may not think it's a good idea. And in fact, we will make you sign a consent form saying that you are doing it against medical advice. But at the end of the day, if you wanted to put in 2 euploid embryos, we won't flat out refuse to do it in most cases. Now, I have had situations where someone has come in and they had a twin pregnancy before and they lost their twins at, let's say, 22 weeks. And then they wanted to put in two more euploid embryos to have another twin pregnancy. And I've said, no, we're just not, I can't do that ethically, morally, it's wrong because, you already lost a set of twins because you put in two embryos. So now we have to kind of draw the line. But in most cases, if you choose to do that, Mel Bell, we will abide by your wish. Now, there are some limitations on that. If you said, well, I want to put in 4 euploid embryos because, we want to have 4 kids, but I just want to have them all at once. We're going to say, no, thank you. We are not going to do that because that is profoundly dangerous for you and would be, really negligent on our part. So there are some limits to that. 2 would really be the most in most cases. Hi to Sugar. Let's see who else we got over here. Rosa says, how long after stopping Orilissa do your periods come back? I am 42 years old with a lower AMH, and that is an AMH of 0.15. So in most people, Orilissa is a medication that we use to suppress endometriosis. Endometriosis is the problem where the lining of the uterus sloughs, instead of sloughing out and creating menstrual blood flow, some of that material works its way up into the pelvis and it implants on the inside. And when it does that, it can cause some problems. One problem is that it creates a pain syndrome, and some people have chronic pain. It's the most common cause of severe chronic pain with a period, which we call dysmenorrhea. That's endometriosis, but it also causes some problems in the fertility world. And one of those problems is that it can cause a recurrent failure of your embryo to stick inside the uterus. Kind of what it does is that it confuses the way the brain talks to the uterus. So much so that it can result in really even up to a 50 to 60% reduction in the probability of pregnancy with any given embryo. And that's pretty significant. So we can test for endometriosis now non-invasively. In the past, the only way that we could make a diagnosis of endometriosis was through surgery. That was through a laparoscopy, which is where we place a camera through the belly button and look around inside the pelvis. Well, now the non-invasive test, it's called Receptiva, and you can look it up on the internet. It's receptivadx.com. Receptiva is a non-invasive test that looks through an endometrial biopsy. It takes a little piece of tissue from the lining of the uterus and looks for the presence of an inflammatory marker that is very highly associated with endometriosis. If we do that test, the marker is called BCL6. If we do that test and it's positive, then we know we need to treat you for that, and 60 days of medication, hormonal suppression, is sufficient to turn off that inflammatory marker in the uterine lining. So Orilissa is one of those medications, and Rosa, sounds like we're using Orilissa. It does. It turns down the hormones. So there's another medication we can use for that that's called Lupron, and Lupron literally puts you into a temporary menopause. It takes all the hormones and quite literally pulls the plug on it. It shuts everything off. As you can imagine, that is somewhat associated with a series of side effects, right? It causes basically menopausal side effects, mood change, hot flashes, night sweats, leg cramps, and things that are, relatively unpleasant. It's temporary. They do go away. However, the oral medications, and there's 2 of them. One is Orilissa, and the other is called Myfembree. These 2 medications are much better tolerated. They're taken orally instead of given as a shot, and have a significantly lower side effect profile because they are more specific for the type or for the receptors, for the place where the medication turns off the hormones. So you don't completely go without hormones. It still leaves you with some hormonal supply, which feels an awful lot better. But because we've turned down the function of the hormones, in some people it takes a little bit of time for those hormones to kind of come back online and do their normal thing. What we really want you to do is we want you to do that hormonal suppression in the 60 days immediately before doing an embryo transfer, and then go directly into an embryo transfer cycle. That's when the outcomes are the best for getting you pregnant. But as you say, it may take a little bit of time for your body to kind of figure out where it was and to turn itself back on. Certainly within a month, I would expect that to be back online there, Rosa. Kristen says, oh, thanks for being here, Dr. Fink. Thank you for being here, Kristen. The Miss Cole, hello from Arkansas. Nice to see you in Arkansas. Okay, let's see who we got over here on my Instagram side. Is it normal to be prescribed Claritin and Benadryl for a frozen embryo transfer preparation? That is part of the antihistamine protocol that comes from Dr. Kiltz, who is our fearless leader. The antihistamines are associated with decreasing a particular type of immune problem that we can all have in our bodies. It's a very basic kind of immune function. Claritin and Benadryl are both antihistamines, but they work on slightly different receptors. That's why you probably know that you can take Claritin during the daytime. Let's say that you've got, seasonal allergies. You take Claritin during the daytime, it doesn't make you sleepy. You take a Benadryl at night because it's going to put you out. That's the difference between the different types of receptors. So they do slightly different things, but that is the reason. This comes from Be Kind, Be Love. Oh, you must have read my sign. Thank you for that. And that's the reason for that. Are you hearing about these this comes from MKid, GLP-1 meds? A woman who is 54 is pregnant with twins naturally. Are you seeing this in your practice? Well, it would be highly, highly, highly unusual for a 54-year-old person to be able to get pregnant, just because the DNA in the eggs, in the ovaries, has been there for 54 years and it becomes unstable. And so to be able to create normal eggs to make normal embryos would be very, very unusual. Now, there is some truth to the fact that they're calling them like Ozempic babies. So semaglutide is the generic. There's another one, Wegovy. These you may have read some articles perhaps on the internet about how these Wegovy babies and these Ozempic babies, that people are losing weight as a result of the medications. And the simplest explanation is that you lose weight and your hormones start to function a little bit more readily, more normally. It may result in ovulation, whereas you might not have been ovulating before, and people are definitely getting pregnant. Now, let me ask you a question, because this is something that I've talked about with Dr. Kiltz. And if you would just kind of throw your answer up there, and I will just sort of qualitatively take note of it. We are actually thinking about starting a weight loss program at CNY. We're still working out some details to see if through telephone or telemedicine consultations, we can provide this category, mostly this category, GLP-1 medications for weight loss. They are not recommended during pregnancy, right? You are supposed to be off of the medication for 2 months before getting pregnant. Because they're just not studied in pregnancy. In my opinion, at some point they will probably say, okay, well, we do believe they're safe because now we have enough data. But currently the party line, the government's position is, and all the professional organizations, is not studied in pregnancy, so you should not be on them during pregnancy. And we say finish them 2 months before you get pregnant. But if CNY were to offer through telemedicine the ability for you to consult with a provider about getting these medications, and using these medications for weight loss. Would that be something that would interest you? So a simple yes or no. Yes, I'd be interested. No, it doesn't sound good to me. Qualitatively, I'd appreciate knowing if you would kind of throw that information up here. Um, and the reason that we're thinking about it, MKID is the same thing that you're mentioning, that people are losing weight and they are getting pregnant. Now, we do not discriminate based on weight here at CNY. It is morally and ethically, it's medically and ethically unsound to say, oh, we are not going to offer you IVF because you are some certain weight. If you got pregnant at home as a result of, with the weight, then life would be as it was. So it is true that with a BMI above 35, there are slightly lower rates of embryos implanting, but at the end of the day, people still get pregnant. And so we don't discriminate. But if we can help with weight loss, if that's something that you're interested in, especially as it pertains to fertility, it is something that is of interest to us. So we are talking about creating such a program. Please let me know your thoughts of that. Kayla Thompson, 31 weeks today because of you. Oh, you know what? I said, oh, you're Kayla from CNY. My mistake there. Oh, Kayla's going to be mad at me. That's awesome, Kayla. Thank you very much for being here. Shabdam says, I had my first ultrasound. I was 6 weeks and 5 days, but there's nothing showing except for the gestational sac. I got a second scan this week. What can cause that? Well, there's a couple of things. The first is we start to, in IVF, we can be pretty certain of the dates that you got pregnant. And so when we think that you're 7 weeks, you pretty much ought to be 7 weeks. In these highly desired pregnancies, I never at a first visit when I would expect to see something in the uterus and don't tell people, this pregnancy is not going to work out because stranger things have happened and embryos floated around. It didn't implant when we think it is. And what are we going to do? I would much rather wait and kind of check again. But there is something that we know of that's called a blighted ovum. And a blighted ovum is known as an anembryonic pregnancy. And what that means is that the pregnancy implants, the placental tissue starts to grow inside the uterus, but there's no baby inside of it. That there was the outer portion of the embryo was normal, but the inner portion of the embryo was not. So as a result, the embryo doesn't grow. It is an unfortunate and sad thing to have happen, but I would also say it's a step in the right direction because at least we know, Shabnam, that your uterus can implant an embryo. That means that things can stick. The brain is talking, the uterus is listening, and at least we're headed in the right direction. So I will keep my fingers crossed and hope that when it comes time to do that second ultrasound, maybe you'll see something. God willing, you'll see a little heartbeat there, and life will feel much better. Hey, it's a little after half past the hour. You're on Fertility with Fink and Friends. I am Fink, and you are Friends. Dr. Randy Fink here, live from Colorado Springs, where CNY Fertility has a location, along with our other locations in Syracuse, Buffalo, Albany, a monitoring center in Rochester. We have a location in Norfolk, Virginia, a monitoring center in Atlanta, and a beautiful location also in Sarasota, Florida. We love being here, and I am here every Tuesday evening at this time, so we can answer your questions and just get together and be with each other because it's a good place to be. Yeah, it feels good to be together. Let's see. It looks like Lily Rios says the Colorado office still delaying the start of stim medications by how many days? It really varies. So let's just talk about that because I do think it's an important consideration that people need to understand. Most IVF practices will batch their cycles. So they may only have an embryologist or an anesthesia person for 1 week out of the month. So they put everyone on birth control pills in order to try to keep every cycle starting at the same time. We don't do that at CNY because we have enough of a, well, I mean, by way of comparison, just had this conversation today, in fact, most IVF practices will do 150 to about 200 cycles per year. At CNY Colorado alone, we do about that number of retrievals per month. So in the CNY system as a whole, we're doing between 15 and 20,000 cycles of IVF. We're doing IVF every single day. We don't, we have anesthesia every day. We have embryologists every day. We don't have to batch people's cycles like that. So we don't do that same thing with birth control. However, for safety purposes, there are a fixed number of what we'll call stem starts on any given day. And I say we do them every day. We don't do them on Sundays, but every other day. So there are a fixed number of stem starts every day, and that is so we don't overwhelm the embryology laboratory, so that we can maintain quality assurance, not just quantity assurance, that we're looking for quality here as well. And so there are a fixed number of stem starts. And if those stem starts are all booked up, then it may be that we put folks on a little estrogen, progesterone priming for a few days to hold off their cycle or to change their cycle around a little bit to a more suitable stem start day. And that comes and goes. That's not just Colorado. That really happens with all of our locations. Colorado has been particularly busy in the last 2-3 weeks. And so there have been some priming weeks or days added into people's schedules so that we could get them started with a safe number of stem starts. But it really, it kind of varies, Lily. It depends on the day. Some days are all booked up, and then it's going to be the next day. So that's kind of how we do that. There's not significant delays. I think at worst it was maybe 7 or 8 days kind of delay, which is very easy to handle with some estrogen and progesterone, and it's actually pretty good for the ovaries there as well. Let's see. I had a question for my protocol. Can we do a dual trigger instead of regular due to my age and low AMH? So almost always, and this comes from, I'm just going to massacre your name there. I apologize. Chop. This comes from Chop. We almost always do a dual trigger. A dual trigger is when, pardon me, the trigger medication is when we tell the ovaries, hey, we're coming for you. We're coming for those eggs. And that causes the last stages in maturity of the oocytes in the ovary, in those follicles, and causes the eggs to start floating freely within that follicular fluid. We give you a trigger usually 35 hours before we're going to do the egg retrieval. So in most cases, it's a double trigger. We use HCG, and we use Lupron. And usually oftentimes it's 2 Lupron shots and HCG. There are some times that we can't use HCG, and there are some protocols that are built specifically just for one trigger, just HCG. So it kind of depends on what protocol you're on there. But in most cases, most of our cycles really across the board are with a double trigger. Now, the one caveat I think of, and you talk about low AMH, there is one particular type of mini dose protocol that I'm fond of using that uses both letrozole and Clomid, along with a low dose of the FSH medication that uses only an HCG trigger because that's what was researched, that's what was studied. So it's not specifically that low AMH requires 2 double trigger, but we find that in general, unless there's some reason not to, that's kind of what we do. Let's see here. Do you use Adderall in any of the protocols? I hear it helps with inflammation. It certainly helps with attention, but no, we do not use Adderall in in any of our IVF protocols. And I'm not sure the mechanism by which it would help with inflammation, but it's an interesting thing. I'll have to look at that. Hey to Equestrian 33, nice to see you. Haven't seen you around for a little while here. Let's see. I had surgery last Monday for stage 3 endometriosis. Dr. Kandra prescribed Orilissa. Should I try naturally or use Orilissa? This comes from Aunt KK2. So the rationale behind both having surgery and using some hormonal suppression for endometriosis is quite simply that when we do surgery for endometriosis, the endo that we can see is going to really just be the tip of the iceberg. So there's always going to be more that's below the surface. And so, we can do surgery and remove as much endometriosis as we can get a hold of, and therefore, hopefully make your life better and such. But there's always a concern that there's residual endometriosis. And remember, we talked about that marker called BCL6. There's a good probability that with endometriosis, even though you had it removed, you may still be expressing that BCL6 marker. And so using the Orilissa as suppression is helpful because it can very significantly improve the pregnancy rate by turning down that inflammation in the uterine lining. So, and KK, I would say, what we want is really to get you pregnant. People say, well, I want to do, everything as naturally as possible. And I say, okay, but naturally really hasn't worked thus far. And there's nothing particularly natural about doing IVF. So really what we want is to get you pregnant. So therefore, I would say using the suppression is probably going to be the fastest path. And certainly, the more reliable path to being able to get you pregnant. Going back over to the Facebook and YouTube side, Liz asks, I've already done my egg retrieval and I'm preparing for my first embryo transfer. What supplements should I be on? That is a very good question. So I wrote a book on that very subject, the Vitamin Victory, and you can attain that book from my link tree, which is linktr.ee/Randy Fink MD, or just look at my Instagram page, Randy Fink MD, and it's the link that's up in the bio. It's a $7 ebook that really goes through all of the evidence-based protocols for egg retrieval, for low ovarian reserve, for embryo transfer, for sperm function, and some other special cases like polycystic ovarian syndrome and endometriosis. And there's actually, in PS, there's a discount in there too if you want to get those supplements. So not a bad thing, not a bad deal for $7. You'll save some money. Five things are in the evidence-based protocol for embryo transfer. Your prenatal vitamin, okay, fair enough. Your CoQ10, your vitamin D, your vitamin E, and something that's called L-arginine. So those are the 5 things that are specifically recommended as part of an evidence-based protocol for embryo transfer. Prenatal, CoQ10, vitamin D, vitamin E, and L-arginine. Now, you can also add some fish oil in that, which is not a bad idea because the moment you're pregnant, I recommend that you be on fish oil. So there's no harm to being on it, but specifically for success of embryo transfer, those are the 5 things. And hopefully that helps you. That's Linktree, linktr.ee/Randy Fink MD. Vitamin Victory is what that book is called. Let's see here. Sally asks, what medication is used to do an ERA? So an ERA, or an endometrial receptivity assay, is done in a standard medicated cycle. So basically it's estrogen and progesterone, just like you were going to be doing an embryo transfer. In most cases, I do not recommend that you do an ERA. Now, if we had talked a year ago, year and a half ago, an ERA would have been a very important part of the evaluation that we do to try to figure out why pregnancies aren't sticking in your uterus. And the ERA was kind of predicated on this idea that 75% of us all have the same implantation window, which means that 25% of people don't. And so we want to find out, are you in the 75% or are you in the 25%? And if your pregnancies aren't sticking, then maybe you're in that 25%. And we need to know your precise implantation timing. Sounds like a great idea, doesn't it? Yeah, it really does. And so for the longest time, it was something that we did, very, very routinely. And you would do a mock cycle, which means, 6 to 12 days of estrogen till your lining is thick enough, 6.5 days or 120 hours of progesterone, followed by the biopsy, as opposed to followed by the embryo transfer. But a great big study came out that really kind of debunked the whole dang thing with an ERA. And it found that looking at tens of thousands of cycles, that there was no difference in the pregnancy rates between people who were on time or early or late. Now, all of us in the IVF business will say, gosh, there have been, I can tell you stories about people who never got pregnant, never got pregnant, never got pregnant. And then we did an ERA, found the timing was off, changed the timing, and boom, they got pregnant. But when you look at all the data, when you look at tens of thousands of cycles, didn't make a damn bit of difference whether you're early, late, or on time. Meaning to say that that window of implantation is likely not as narrow as we thought it was in terms of timing. So I no longer recommend an ERA. It would be a very rare day that I will recommend an ERA. So I would be very cautious about that. Now, the internet doesn't, people still talk about it, and you'll read on the Facebook pages and stuff. Well, I did it, and that's what got me pregnant, so you should definitely do it. The data says no. So it is generally, people want to do it, we certainly will, but it's not inexpensive. So it's not so much something I recommend. I think for recurrent implantation problems, the Receptiva test is a much better test to do, because that issue with endometriosis, silent endometriosis, is extremely prevalent, especially in a fertility population. So I think that's a much better one to do rather than an ERA. But to answer your question, it's a mock cycle like any other medicated cycle. And instead of getting the transfer, you get a biopsy. Now, the Receptiva test is also supposed to be done at a particular time during the cycle, and that's usually 7 to 10 days after ovulation, or really about the same time as you would otherwise be having an embryo transfer, like if you did a medicated type cycle. So in theory, they can be done at other times, but it is labeled and indicated for being done at that specific kind of timing. I hope that helps you. Hi to KB. Hubby had a vasectomy. Could you talk about the chances of IVF working? Yes, absolutely. So IVF is really kind of the choice in most cases. So in the issue of a vasectomy, the tubes are being cut, right? So the tubes are, the sperm is manufactured in the testicles. They're stored in a little structure that lives behind each testicle that's called the epididymis. When it comes time for them to start moving, they go through a little tube that is called the vas deferens, also known as the ductus deferens, and eventually they work their way, to the outside. A vasectomy is when that tube that transports the sperm from the vas deferens, or rather from the epididymis, on their way out the door, as those tubes are cut. All right. So what's happening in that situation is that the man is still making gazillions of sperm, as long as the testicles are, were normal to begin with, and he's not on some medication like testosterone. He's still making he's making all the sperm. They just have no place to go because the exit has been blocked. So what's done is, by a special type of fertility urologist, who is a male fertility specialist. There are a series of different treatments that they can do, procedures that they can do in order to either aspirate or extract sperm. That sperm, again, he's in most cases he's making all that sperm, just the doorway is blocked, so they just need another way to come out, which is done through a needle. So they put some numbing medicine in and are able to get the sperm. Then we take that sperm, it goes to the laboratory. One sperm goes inside each egg. And that's how you get pregnant. So some people say, well, what if I don't want to do IVF? Do I have to do IVF? I mean, we don't have infertility, right? Well, yeah, you do, because you're not making any, the sperm aren't coming out. So that's infertility. That's a male factor type of infertility. Do you have to do IVF? Why would you do IVF instead of something like, let's say, IUI? Well, an IUI, or an intrauterine insemination, is where partner gives us sperm. We prepare that sperm in the lab and place that sperm back inside the female at just the right time in order to try to maximize the probability of sperm being able to meet egg. Well, that's a good thing, right? That sounds like a good thing, maximizing probabilities and such. Isn't that what you really want to do? Yeah, absolutely. It's less invasive than IVF. It's less expensive than IVF, but it is also significantly less effective than IVF. And so IUI with ovulation induction, so we give you a little medicine to make sure you're going to release an egg, confers about a 9% probability per cycle, or per month, per menstrual cycle, of you being able to get pregnant. 9% per cycle. Compared to IVF, which can confer up to a 65% probability per embryo of you getting pregnant. So the odds are just significantly higher using IVF. And the problem is that, okay, well, doing that sperm aspiration or sperm extraction procedure, it's not a terribly big deal, but yet it kind of is. It's not something you really probably want to do all the time. And so, typically what happens is they get enough sperm for about 4 vials, and figure if you use, call it a vial of sperm every time you do a procedure, and that's about what you use there with your IUI, that's going to give you 4 cycles of IUI. And then the sperm is going to be gone, which means you're going to have to do that sperm extraction procedure from the testicle or from the epididymis again. And so given that kind of thing, it probably makes more sense to do a procedure that is going to be more effective and have a much higher pregnancy rate, and that would be IVF. Could you do it with IUI? In most cases, as long as the sperm count was normal. You can if you want to. They're your testicles, and and they're your eggs, and it's your money. So you certainly can, but generally speaking, it wouldn't be advised. Jessica, let's see. I missed one there. Sabi Cologne says, I ovulated through estrase last month and had to cancel my FET cycle. The second round I've been doing, I am Del estrogen for 3 weeks, but having issues with a thin lining. It went from 5.3 millimeters 4 weeks ago, and eventually up to 6.4 last Friday. I did a PRP treatment as well, but my lining still only measured about 6. I had some fluid in my uterus that was removed. Kind of what's going on here? Well, so this is a frustrating situation there, Sabi, that you have a uterus that's trying its hardest not to respond. So what are some of the things that we do when we can't get that uterine lining to get thicker? And you're talking about, many of these things. You're talking about, so we use some oral estrogen, we use some vaginal estrogen. Some people just don't absorb either of those things very well, so we can use some injectable estrogen, and that's what Del estrogen is. That's what that's called. We will often place you on Viagra, and we do things like intrauterine PRP, like we talked about before, the platelet-rich plasma inside the uterine lining. to try to get you to respond. Now, some people still have a real hard time responding. So even when we've done all that, if that lining has gotten to about 6 millimeters, I would proceed, because my guess is that if I took the right kind of ultrasound instrument and looked at the blood flow that was going to the lining, we would probably find that it was adequately served by blood flow. The other important consideration is it thin, but it's also trilaminar, and trilaminar, 3 layers, means that you can see the top layer and you can see the bottom layer and you can see the interface between. So they kind of look like, it looks like lips, and kind of, it looks like Mick Jagger's lips, kind of like that. 3 layers. If it's 6 millimeters and trilaminar, after all that stuff, my guess is that the blood flow to it would be fine, and I would proceed. Let's see. I had a hysteroscopy done in March of 2024. Do I need a new one for my transfer in October? No, we like you to evaluate your uterine cavity really once a year. So if you've done that, I think you're good. Coming to Colorado, Faith says to you to do my second FET on Monday. Outstanding. We'll look forward to seeing you. Rabbit Ariel says, do you have donor embryos? I had breast cancer and would like to get pregnant. Yes, CNY does have donor embryos. The wait list for donor embryos is often a long one. So the other thing that you can do there, Ariel, or is it Rabbit? One or the other, Rabbit Ariel. The other thing that you can do, my friend, is if you have a partner or a sperm donor, is that basically you can make your own embryos. You get a donor egg, and either you use your partner's sperm or you can use donor sperm, and then you can make an embryo. And you can really walk into that process, kind of next month, as opposed to saying, well, we want to take an embryo that's already been created and use one of those. Those donor embryo lists, like I say, are often very long, whereas making your own embryo with a donor egg is probably a much faster process. Does luteal phase stimulation end up with more follicles for a low AMH? So sometimes it can lead to actually fewer follicles, but sometimes they can lead to more. I am not a huge fan of luteal phase stimulation unless it's being done for somebody with a low AMH in the second half as what's known as a duo stim. So you do your first retrieval, and about 4 or 5 days later, you start your next stimulation right away. That's the way I find a luteal phase stimulation may be helpful, particularly in someone with a lower AMH. If embryos are already frozen, is it too late for PGT testing to find out the gender? Well, we can take an embryo, and that comes from Cal 823. We can take an embryo, we can thaw it, and we can biopsy it and refreeze it and send the PGT off and get those results back. But then when we find the normal embryo, the euploid embryo, we have to thaw that embryo again. So it goes through a thaw, a biopsy, a freeze, and then another thaw, and then a transfer. So theoretically, that has some risk, or can have some risk on the embryo itself. In general, I would say there are some scenarios where I think that's useful if you're doing it just for gender selection or sex selection, or people have different views about what you should call that. It's not gender, it's sex. It's not sex, it's gender. Okay, if you're looking to see its sex chromosomes, you can't go wrong with that. I would say I think that's pretty risky to do with an embryo. Embryos each have their own little tank of gas. And every time you do something with that embryo, it's going to use up some of its gas tank. And if you have a blastocyst, let's say a day 5 embryo, and it's frozen, and you thaw it, that's going to use some gas. And then you biopsy it, that's going to cost it some energy too. And then you freeze it again, that's going to go through that process. It's going to use up some more gas. And then you find out it's normal and you're going to transfer it. That's going to use up more gas. At some point, its gas tank is going to be empty. We don't know at what point that is, but could that have some risk? Yes. If you have a day 3 embryo, you're really better off saying, let's thaw our day 3 embryos, see if we can grow to blast, then biopsy, and then freeze. That I feel much better about, because those embryos continue to resupply their own gas tank. They're not stuck at that blastocyst stage, if that makes sense. So there you have it. Let's see. We got a couple more minutes here. Let's see. Chris, 1524, got my husband's sperm analysis and it came back 99% morphology abnormal. What does this mean? Well, it's interesting about sperm morphology. Morphology is not considered to be a cause of infertility. And in fact, if you look at you'll have to go back. I did an Instagram video on, it's both on mine and somewhere on CNY's, about sperm morphology and what do those sperm look like, what happens in a semen analysis. It can be very subjective. So any two embryologists or andrologist technicians looking under the slide may not come up with the same number. But what's normal, get this is it's unbelievable. What's normal is that 96% of sperm can be abnormal and that only 4% can be normal in order to call that normal. So 99% means, all right, there is 1% normal forms. Well, what's normal is 4% normal forms. So that's, a little lower morphology, which has a term, it's called teratospermia. And it just means that when you're doing, it's associated with those who have problems getting pregnant, but it is not a cause of infertility because, we could go out into the general population and test everybody's sperm. We probably find there are a bunch of people who are abnormal that didn't have any, with morphology, didn't have any problem getting pregnant. So, yeah, hard to say. But that's a difference between 1% versus 4% abnormal forms. And if you're doing IVF, that's a pretty easy thing to overcome. Guess what, folks? We are going to be out of time today. I am so sorry. I could sit here for another couple of hours and spend this time with you because I sure do enjoy it. And I sincerely appreciate the fact that you guys are here for each other and for me. I love being here for you. Every day forward should be a new day in kindness. Share that. Bring that everywhere you go because it makes a difference in this world where there is not enough kindness. Lead forward every day with hope, knowing that tomorrow is a new sunrise and a new day, and all those problems from today and yesterday are really then just a construct of our imagination. They don't exist in physicality anymore because when the sun comes up, there we are. This is all about you. This is not the book of your life. This is only a chapter. And what we're doing is trying to rewrite it together. So until I see you next week, thanks so much for being here. I'm Dr. Randy Fink from Colorado Springs. Good night.